It is now my privilege to introduce Dr. Carrie Epps. Dr. Epps is the chair of the Texas Collaborative for Healthy Mothers and Babies. Dr. Epps is a maternal fetal medicine physician at Baylor College of Medicine and is the chief of obstetrics and for Ben Taub Hospital. She received dual degrees in molecular biology and psychology at the University of Texas at Austin. She received her medical degree from the University of Texas Health Science Center, San Antonio, and completed residency at Johns Hopkins. Her fellowship and her Master's of Public Health degree were received from Northwestern University. Her primary areas of focus are quality and safety and infectious diseases in pregnancy. And Dr. Epps is the Texas AIM Faculty Medical Director. Dr. Epps, Carrie, it is great to have you here today.
Thank you so much, Dr. Lakey. And I just want to echo a thank you to you and to Dr. Hall for everything that you do for moms and babies around the state of Texas. Before I get the great privilege of talking about the work that TCHMB has done over the past year, I just wanted to take a quick moment to acknowledge and thanks all of the TCHMB staff who worked so hard to put this conference together, and we certainly hope you all will enjoy it. So now I get to talk about all of the work and the goals and the priorities of TCHMB since some of you we met a year ago and some of you this might be your first summit. Next slide, please. So some of the things that we'll cover today include the data for our state in regards to neonatal and maternal outcomes. And this is really the data that guides the work of TCHMB. So committees like our State Maternal Mortality and Morbidity Review Committee and their findings and our vital statistics data let us know what we need to be focusing on in our state to improve health outcomes. That's also how TCHMB sets its strategic priorities. And as an example, something we'll review in the slides coming up, knowing that we have stark healthcare disparities, we know that this needs to be a top strategic priority for TCHMB. So over the last year, we have done another alignment of our mission and our goals and our focuses for the next 5 years. I'm going to talk a little bit about the work of our race equity work group and how they are going to help in structuring everything that we do going forward to make sure we are targeting and improving our inequitable health outcomes. And then finally, I get to talk a little bit about some of the very exciting quality improvement projects that you'll hear more about through the next few days. Next slide, please. So I'm going to start with talking about some of the data that we have in maternal and neonatal health outcomes. And this is from the March of Dimes Premature Birth Report Card. And they have given all of the various states a grade, and you can see that as displayed by the colors. And unfortunately, you can also see, therefore, that Texas has been given a grade of D in regard to premature birth. And some of the things that go into this information include looking at health outcomes, healthcare access, so things like Medicaid extension or expansion, healthcare utilization, and some social measures, including things like social vulnerability index and rates of prenatal care. And in Texas, we have a premature birth rate of 10.8%, which is part of what has led to this grade of D. And our disparities ratio is 1.26, with our Black moms having higher rates of preterm birth. And that has not changed from baseline. And this is part of what goes into this grading system. And notably, some of the counties within Texas, including Bexar, Harris, and Hidalgo, have been given a grade of F by the March of Dimes because of our preterm birth rate greater than 12%. And they've looked at a number of features, such as our rates of inadequate prenatal care that go into this. And so that's a sobering thing to look at and reminds us that this needs to be a clear focus going forward. Next slide, please. This is data from our state Maternal Morbidity and Mortality Review Committee, looking at the leading underlying causes of pregnancy-related deaths in Texas. And this is data from 2013, published in a report in 2020. And you can see the top causes of death include cardiovascular and coronary conditions tied with mental health disorders, which includes substance use disorder. Tied for the second place include things like obstetric hemorrhage and preeclampsia, eclampsia, notably things that our state via Texas AIM are specifically targeting with safety bundles, knowing that these are often things that happen in the delivery hospitalization or immediately postpartum. And you're going to hear later on today about the next QI project from our obstetrics committee looking at postpartum preeclampsia and what we need to do to improve that. And of course, I think we all expect infection to be a higher cause of death as we get more contemporary data from our state in regards to the COVID pandemic. Next slide, please. So the MMMRC committee also reviews each of these cases and looks at the degree of preventability in regards to these pregnancy-related deaths. And almost all, with the exception of cardiomyopathy and embolism, have been found to have some chance or a good chance of preventability. Now that's good in that there are things that we can be doing differently, quality improvement projects, hospital structures, processes, et cetera, that should therefore lead to a reduction in morbidity and mortality. And I'm just going to highlight here, since this is a focus of both TCHMB and Texas AIM, preeclampsia and eclampsia has a 100% chance of preventability, either graded as some chance or good chance. So again, there are definitely things that we can be targeting to improve these outcomes. Next slide, please. The next two are going to look at our healthcare disparities. So this slide is looking at the rate of delivery hospitalizations with any severe maternal morbidity. And severe maternal morbidity is defined as a set of validated ICD-10 codes in association with a delivery that have been looked at and known to be associated with poor outcomes. So for example, if a pregnant woman comes in and delivers and has a heart attack, that would be a severe maternal morbidity. And there are a whole set of codes that are associated with this. And you can unfortunately see, and has been persisting, that our non-Hispanic Black moms have worse rates of severe maternal morbidity compared to our non-Hispanic white and Hispanic moms, or those who identify as other. This is just one of the things that lets us know that in order to improve outcomes, we have to specifically target things that make more equitable outcomes and reduce these disparities. Next slide. This is looking at infant mortality rates, and you see a similar pattern to what you see in regards to severe maternal morbidity, with our non-Hispanic Black infants having a higher mortality rate than other races and ethnicity and the overall average within Texas. Next slide. So what does this mean for our state and our state perinatal quality collaborative? So just as Dr. Lakey mentioned and Dr. Hall mentioned, TCHMB is our state perinatal quality collaborative. This is a map looking at all of the states in the United States, and you can see almost all of them either have an established PQC, have a PQC that's receiving funding from the CDC, or are in development. And this has really become the framework in which to improve care for mothers and babies throughout the United States. And many of them use a similar pattern to what our state PQC does, where we do collaborative learning models. So we are working on sharing best practices, lessons learned, successful strategies among hospitals. I can't emphasize enough, as states before us and after us have definitely become aware of the importance of timely data to drive QI improvement, and then finally using quality improvement science framework to develop those statewide quality improvement projects. And these are all things that are part of the core values and strategies of TCHMB. Next slide, please. So the mission of TCHMB, and we just went through reaffirming and looking at and adapting our mission. So our mission that we have established is to advance healthcare quality, equity, and safety for all Texas mothers and babies through the collaboration of health, and community stakeholders as informed by the voices of the patients we serve. And I just want to draw attention because we added a couple of key things, largely informed by the data you saw before, including the addition of equity, because we cannot have quality without equity. It is one of the core pillars of healthcare quality. And we know from the data we just looked at how important that is, especially within our state. And also to add the voices of patients we serve. So those who have lived experience, having them inform and really drive what we're doing for quality improvement. And therefore, these are additions to our mission that we have developed this year. Next slide, please. So what are our goals? Again, many of these are things that have existed previously for TCHMB, but taking a good look at what we have been working on and what we have ahead of us, we've added a few things. So clearly from what I demonstrated in slide 2, we know we need to continue working on reductions in preterm birth, reducing morbidity and mortality for mothers and babies. We added, and I'm embarrassed to say that it wasn't there before, but clearly it's extremely important, eliminating health outcome disparities and inequities for mothers and babies, especially those associated with race and ethnicity. Improving the health outcome of mothers and babies using the life course approach, so looking at over the entire course of their health and lifetime. Strengthening the involvement of partners and families with maternal and child health, so really using those who have real experience to let us know what is important and how things would be beneficial to them, and improving the health environment for mothers and babies. And so these are the things that you're going to see us working on over the next 5 years. Next slide, please. So how do we do this work? It relies heavily on our infrastructure. So I'm going to just talk a little bit about our leadership structure, and then also do a quick reminder that we are actively looking for new chairs for a couple of these committees. So we have an executive committee, and it is also formed by 4 core committees, which include community health, obstetrics, neonatal, and now newly reformed our data committee. Next slide, please. These are the very hardworking members of our executive committee. I'm going to talk a little bit in the future about the alignment and merger that we had with the RAC and PCR system. And so we're really excited to have added on all of those collaborators that have really strengthened both the geographic representation, infrastructure, and abilities of TCHMB. Next slide, please. So just a quick notice or reminder if you've seen it. We have had 2 very hardworking community co-chairs, and that is June Henke and Janet Dukes, and they are both about to finish their term. Janet has luckily offered to stay on a little bit, but we are actively recruiting for 2 new community chair members. And very importantly, the mission of that committee is to strengthen the work of the neonatal and OB committees by including and involving and strengthening the community involvement. We've also had a data work group ongoing for the past several months, looking at what does a good data infrastructure need to look like for Texas, and we are now actively recruiting for 2 new committee co-chairs. Next slide, please. So taking just a quick step back, looking historically, could you go back 1 slide? Looking historically at our overall timeline for TCHMB, we are a relatively new PQC looking at the rest of the US, and we actually formed in 2013 and initially was an expert panel called Healthy Texas Babies that during that time transitioned to become the Texas Collaborative for Healthy Moms and Babies, or TCHMB. And at that point, it was coordinated and facilitated by DSHS, and we had 150 members. In 2015, the UT system, via UT Health Science Center at Tyler, began to support the work of TCHMB through a contract with DSHS. And then we started our first few quality improvement projects. And you can see through this timeline, they have grown in volume and size and in participation over the years. And very importantly, in October 2019, we integrated the Perinatal Care Region Alliance within TCHMB, and that tremendously strengthened what we are able to do for our Texas moms and babies. Next slide, please. For those of you who might not be familiar, although I think certainly with maternal and neonatal levels of care, our hospital populations are becoming very familiar with this process, but our state is divided into 22 care regions. And we have obviously very diverse representation in a very diverse state. And so it's really important to capture that in any projects that we're doing so that we are actually meeting the needs of our entire state. And so this merger between the PCR and TCHMB has tremendously improved that geographic representation. Both the OB and the neonatal committees have all 22 different regions, have a member of the committees. And therefore, we're really improving the work that we're doing in respect to quality improvement. Next slide, please. So a little bit about past initiatives from TCHMB, and you might hear pieces of this throughout the next 2 days, and you'll certainly hear a lot about our upcoming or current projects. But you can see from this timeline, each of these projects have sort of targeted a different time period in maternal health or neonatal health. And just starting from the top, for an example, we started initially with a project to increase breastfeeding and human milk in the NICU with 15 different hospitals. This was one of the first projects of TCHMB, and it targeted level 3 and 4 NICUs and about 800 NICU beds. Our OB committee started with a project to reduce failed induction of labor, and that had 3 hospitals at that time and is now in maintenance phase. And then took on, in partnership with work being done with Texas AIM, maternal early warning systems. So a response system based on severely abnormal maternal vital signs that results in more prompt action. And this was disseminated through all participating Texas AIM hospitals, so all 219 hospitals, but with a real focus on about 15 that were driving the work, deeply engaged in a learning collaborative and reporting on data. Our community committee has done work on increasing access to reproductive health and had 3 different health systems involved in one key question, which is a set of questions regarding if, when, and under what circumstances patients might want to become pregnant, so you are adequately addressing their reproductive health care. And also a project regarding postpartum access to healthcare, looking at that critical postpartum time period, including what the barriers and successes and opportunities are. And I think one of the things that became really clear is just how complicated knowing what coverage will get patients covered for what their need is at which point in time, and led to a reference sheet on public health programs. If you haven't seen it, it's available on our website and shows different coverage models and what is covered at which point in time for pregnant women in our state. Next slide, please. So what are we working on currently? We've recently had the development of our race equity work group, and I'm going to talk a little bit about that in a couple of slides and several of the things that they are working on. But overall, this is to make sure that all projects, all programs, all interventions that come out of TCHMB are created with a race equity lens in mind. Our OB committee is in the process of developing a project in partnership with Texas AIM, looking at the critical postpartum time period in regards to preeclampsia and improving collaboration with emergency departments to recognize and respond to preeclampsia during that time. And then our newborn admission temperature project that has a huge statewide participation, looking at maximizing normothermia for all infants born at birth, for all infants. Next slide, please. So a little bit more focusing on our race equity work group. As I mentioned, this is an absolutely critical piece of work. And this group has really been tasked with making sure that every project we create is making sure to address where a healthcare disparity currently exists, paying attention when one develops, and having strategies to eliminate those inequities. Next slide, please. So they have developed a framework and a group to make sure all of our projects pass through and are given that specific look to ensure that we have incorporated equity into the project. So that includes things like disaggregating our data by race, ethnicity, and language, or other things that might result in inequitable care. Looking at where those exist at baseline and making sure the project is targeting reducing that, or if they develop, that we are able to capture it. And so some of the important framework pieces, including all QI projects and our strategic plan, now specifically incorporate race equity framework. We did a training in the last year's summit, and we'll do another this year, specifically looking at features of healthcare disparities. And then we've had a series of webinars, with one recently being given and 2 more planned, looking at collection of real data. Next slide, please. And I'll just say, both our OB committee and our neonatal committee, the projects either in development or currently ongoing, are specifically looking at collecting data so that we can be measuring some of those important healthcare disparities. We recently had a webinar on getting real with real data, looking at exactly how you make sure you have valuable information that is being collected so that you can actually stratify your data by race, ethnicity, and language, why that is important. So concluding anything from the admitting folks to the data collection folks to the clinicians and the quality improvement people. And we have 2 more planned webinars. If you weren't able to see this, it is available both as the slides and a recording on our TCHMB website, and I strongly encourage you to go look at it. We do have 2 planned upcoming, so if anyone has any specific topics that you are interested in, we certainly will take input. Next slide, please. And finally, I'm going to talk a little bit about our quality improvement projects, and you will hear more about this throughout the day. As a state PQC, this is obviously a huge focus of what we do. And the first is to look at our newborn admission temperature project with the work group lead Rashman Savani and the staff lead Divya Patel. Next slide, please. So the project overview and goal. The NAT project is a QI initiative hosted by TCHMB in partnership with that new RAC perinatal committee framework to increase the proportion of newborn infants with admission temperatures in normal limits through the implementation of best practices. Next slide, please. This is a little bit about where we are in this project. So enrollment began in November of 2020. Very enthusiastically, so many hospitals participated, which I think just shows the strength of our new collaboration with the RAC PCR system. And I've been told this is now the largest neonatal project in history in our state. It was launched officially 2020. Hospitals have been reporting data, and our final data is due April 31st of 2020. Next slide, please. So again, this is a look at the breadth and depth of participation. So we have 229 hospitals that take care of neonates in our state. We have 157 enrolled, 44 hospitals in progress, and really only 28 hospitals not enrolled. So I think this just goes to show the incredible enthusiasm of hospitals in participating in quality improvement projects, and how we have good geographic representation. So thank you to everybody whose hospital team is participating. Next slide, please. Just a little bit about our upcoming project looking at postpartum preeclampsia in the emergency department. And there's going to, of course, be a little bit more about both of these in the OB and the neonatal tracks on day 2. The work group leadership for this project is Lolly Perry, Gloria Delgado, James Hill, and the staff lead Naga Alarian. And I'm just going to add that Christina Davidson has also been instrumental in this, and we get to work in very close collaboration with the entire Texas AIM team. Next slide, please. So as some of the slides at the beginning of the presentation reviewed, we know that there is a high percentage of our maternal deaths that are related to preeclampsia and eclampsia. 11% from our state MMMRC of the maternal deaths were found to be related to preeclampsia, eclampsia, and the vast majority of these happen within 42 days of delivery. I can tell you we know that's a very vulnerable time period for pregnant moms, and from data from Texas AIM, it does seem that people present back to care after delivery through a very wide variety of different venues. So some to emergency departments, some to OB units, some to freestanding ERs. And so this project seeks to reduce maternal morbidity and mortality related to severe hypertension in the postpartum period. Next slide, please. So the work group is still developing several specific features, but overall, a paramount feature is the coordination with emergency departments and in emergency care for postpartum patients that might present with signs and symptoms of postpartum preeclampsia. This is, of course, complicated because not all patients will identify that they are immediately postpartum, and a blood pressure of 160 is not typically an emergency room red flag, whereas it is for people who have recently delivered. This project will complement the work of Texas AIM, led by DSHS, in implementation of the severe hypertension safety bundles. And project components include improving teamwork and collaboration with emergency departments and labor and delivery units, facilitating education in a multidisciplinary fashion with emergency department clinicians so that we can improve recognition, diagnosis, and treatment, and development and dissemination of clinical management tools to help those in the emergency department. And so if you're interested, please attend the neonatal and the OB sessions on day 2 to hear a little bit more about the projects. Next slide, please. And then finally, and as Dr. Ramsey has addressed a bit in the sidebar, we have a number of different resources available for folks on our TCHMB website. So the first is a couple of myth versus fact documents, one in regards to postpartum tubal ligation and some complexities and questions that have existed regarding funding, reimbursement, consent. We have one for preeclampsia, so including things like not to attribute a patient's severe range blood pressure to things like pain or anxiety, and the importance behind actually knowing the medical evidence in these. And we have one upcoming in regards to congenital syphilis. We have numerous resources to support our quality improvement projects, so webinars, videos, and toolkits. On the right-hand side is just some examples. So this is a Muse badge buddy that many hospitals have ordered to help with maternal early warning system projects. The top right is a video that was put forth during our Muse project. And then the bottom display is looking at our reference sheet to understand healthcare and what is reimbursed in the state of Texas to help our patients navigate through the system. We have our annual summit as a huge resource with handouts and recorded sessions, hopefully to address key important topics. That is why this year is focusing on patient-centered care. And you'll see a lot of really good sessions on things like shared decision-making and the importance of listening to our patients. And then there are links to external resources as well, which you can see from the website listed here. So as an example, we had links to things to further help during COVID and our quarterly newsletter. So please, I hope that this helps you in your ongoing quality improvement work in your setting, whatever it might be. Next slide, please. So most importantly, thank you all for joining us today. Thank you for having a commitment and an interest in healthcare for our mothers and infants in our state. As Dr. Lakey mentioned, we have a really great summit ahead with a lot of fantastic speakers. As an example, in the afternoon, we've got a group talking about shared decision-making and the importance behind it. I actually took a similar course that they gave a number of years ago, and it completely changed the way I interact with patients. Just as an example, I recently, as many of us probably had, got sick with COVID and did a telemedicine visit, and I watched that provider use shared decision-making back with me. and at the end say, all right, did we address what your one main concern was today? Which of course made me realize, even as a clinician, I had forgotten the main reason I had called, which was, wanting to explore a treatment option. And so it allowed us to bring that back up. So I think this is an extremely important feature, and I hope you all enjoy the rest of the summit. Thank you so much. And